Welcome to the Pregnancy Help Podcast. I'm Christine Grimm, and I'm joined by Heartbeat International's board chair, Gary Thome, who's been on our podcast before, although it's been a couple of years. And Gary's been a key member of our prenatal diagnosis initiative team, and some really amazing things have come from that project. We've talked about it on the podcast before, and I'll link to more of that in the show notes. And I know we'll be discussing some additional pieces throughout our conversation today as we talk about the support that's available to families facing a prenatal diagnosis with their unborn child. So we're also joined today by Dr. Martin McCaffrey, who specializes in neonatal perinatal medicine and will be helping us better understand things from a medical perspective, because we know there's a difference between a diagnosis and a prognosis, and the outcomes, even with the same diagnosis, can vary. So let's get started. And Gary, let's just give a quick overview of the Prenatal Diagnosis Initiative through Heartbeat International, and then we'll jump into the conversation with Dr. McCaffrey after that.
Right. Well, thank you, Christine. So this actually got started several years ago and developed into kind of a working group of several different pro-life organizations that were really interested in helping parents through the journey, some of which had deep experience and expertise, others who were very interested in it. And as we worked together, we really felt that we could develop some ability and capabilities to bring to parents at a larger scale than any of us could do on our own, and be able to minister to parents who are receiving a prenatal diagnosis, and work alongside the medical community in a way that can help those parents journey through this different form of a unplanned pregnancy, not really an unplanned pregnancy, but really an unplanned diagnosis for a pregnancy, which can result in a crisis for parents similar to an unplanned pregnancy can. Just the needs are different. And so, how do we effectively walk with those parents through their unique needs? But the journey of walking with parents is very similar in a parallel way to any other unplanned pregnancy. And we'll talk more a little bit later on, but one of the things that we have available is a website called prenataldiagnosis.org, which, amongst other things, most importantly, helps provide referrals for parents to pregnancy help organizations that are especially trained to be able to walk with them through that journey. So we're here with Dr. Martin McCaffrey, who's a specialist in this area, but thank you first off so much for joining us on this podcast.
Thank you, Gary. No, thank you.
Yeah, and maybe we can start with just kind of some of your own background. I've heard some of this, myself, but just for everybody, just kind of your own medical background and your experience working with families facing prenatal diagnosis. And I know you've kind of had your own journey in that as well. So maybe you could share that with us.
Yeah, sure. So I think, how I got started on this trail of trying to really help support and advocate for families with a prenatal diagnosis goes a ways back. I would say that probably there are at least two pivotal moments for me in my career. I trained as a neonatologist. I did my fellowship at University of North Carolina, Chapel Hill. I'm a Navy-trained pediatrician. And when I came out of training in Chapel Hill, went back to the Navy. So that's a little bit about my career. I did my Navy career and then headed back to Chapel Hill, where I was grateful enough to have a spot for me to be able to come back. And that's where I am at this point. That was in 2006. I would say the pivotal moments in 2000, we had our daughter born, Shay, with Down syndrome. And it was really kind of an eye-opening experience for me because we went through this pregnancy constantly being asked if we wanted to have prenatal testing. At the time, we did not have the extensive prenatal testing we now have. And we repeatedly told people no. And this was at my home facility, where I was the director of the neonatal intensive care unit in San Diego. People very regularly, every other visit, asking, did we want these prenatal tests, and repeatedly saying no. And at birth, Shay was clear to myself and my wife, Teresa, who's a NICU nurse, that Shay had Down syndrome. What was interesting, a side note, is that everybody who came and attended her delivery was totally in denial that she had Down syndrome. I mean, Teresa and I knew, but everyone was, no, you're overcalling this. But no, she did have Down syndrome. And it made me very aware over the next number of years about the advocacy issues related to the Down syndrome community. A classic example occurred early on for us. After Shay was born, went home, had a pretty short NICU stay, about 2 weeks or so. And we were in follow-up coming back to pediatric clinic, and we met an acquaintance out in the courtyard at the Naval Medical Center in San Diego. And Shay was with us, of course, at the follow-up appointment. And this person said to us, oh, you had your baby. And we said, yeah, how was it? Well, we said it wasn't quite what we thought it would be necessarily. Shay's got Down syndrome. And this acquaintance said to us, well, didn't you have the test? And I thought to myself, are you serious? I mean, this is a beautiful little baby here sitting in front of you. And what are you asking that then inferring that we should have done? But that started me on the road for Down syndrome advocacy, as well as my wife, Teresa. Fast forward a little bit to 2009, and Shay and I went up to a news conference. It was really a press conference for families of kids and people with special needs and the impact that the Affordable Care Act was going to have on them. And I went up there with Shay, and I was going to be speaking at that press conference. And at that meeting, I met 10 or 15 families with children, not with Down syndrome necessarily. There were a couple, but with children with trisomy 13 and 18. And they weren't just children. They were teens. There were a couple of young adults. And I looked around this group of folks and I said, are you sure that you all have trisomy 13 and 18? Because for me, as a neonatologist, what I had been taught, and up until that day, what I was doing and believing was that these disorders were all lethal and that none of these babies could survive. And if they did survive, it was very rare. It was only 5% said, Marty, we're not mosaics. We're not partial trisomies. Our children have full trisomy 13 and 18. You just don't know the data. And I was like, okay. And I spent the day with these folks, and I went home and I looked at the data, which I'd never looked at before. And I'll be darned, but the data was pretty clear back into the 80s and 90s that there were select groups of these people, these children, these babies, who were surviving at a year about 40% when the parents opted to make interventions for their kids. And I had to look at that and say, this is clearly not lethal. And then a couple of years thereon, after I changed my attitudes towards children and families dealing with prenatal diagnosis of trisomy 13 and 18, I had the privilege of working with a family who had conjoined twins, Siamese twins. And that family had traveled the East Coast looking for people that would be willing to support the birth and the care of their babies and not recommend that they terminate the pregnancy. And they ended up at UNC, and we did a really great job. I'm really proud of the job we did. But what was really incredible for me was that family was working with a group called Be Not Afraid and Tracy Windsor. And Tracy, who was one of the founding members of the Be Not Afraid organization, came and actually met that family. We bonded over that family. And that family had those twins survive for almost 2 weeks, not quite. But it was the most beautiful, loving experience. And unfortunately, the babies were joined at the heart and they couldn't be separated. And they both ended up passing away. They both ended up dying. But Tracy and I were named godparents for these children. And that began for me an incredible relationship with an organization that was absolutely committed to helping parents, as you said, walk down the road of prenatal diagnosis, get their babies to a live birth, and hopefully beyond.
Yeah, well, thank you for that. And we're certainly going to get back around to Be Not Afraid again in just a few minutes. Maybe, just kind of listening to share stir a couple things. One is share a little bit of medical information for everybody here, kind of what does it mean to be a trisomy? And the other is just, it sounds like those two experiences really profoundly affected kind of, how your attitude was and is in terms of how you interact with parents who are experiencing this.
Yeah, what happened with those experiences is it opened my eyes to how the medical community was viewing these families. And I'll say that my attitudes at the time viewing a number of these disorders or genetic anomalies like trisomy 13 and 18 as lethal was based on what I was taught and what was in the literature, and that's all I knew. So it was really ignorance on my part, and it wasn't for any reason that I thought differently about these babies or these children, but it just seemed like they didn't have an ability to survive. What I realized is that having an extra chromosome, which is what trisomy 13 is, an extra 13 chromosome, trisomy 18, an extra 18 chromosome, or just like Down syndrome, an extra 21 chromosome. But having an extra chromosome doesn't dictate what your medical course is going to be. I mean, you may have a diagnosis of trisomy, but my thought is, and my experience is, if you've seen one baby with a trisomy condition, you've seen one baby with a trisomy condition. And they all manifest very differently. What the medical community was and still is fixated on in most places, not everywhere, it's getting better, is that these are still really challenging disorders that can be sort of thought of collectively as a baby with the trisomy 13 or the trisomy 18, and that ultimately, even though the language may have changed over the years, where many people are hesitant to say lethal at this point because they realize that's not politically correct and acceptable to a number of folks, never mind the fact that it isn't accurate. They'll use language like life-limiting disorders. But the fact is that many of these children now we are seeing when we do provide care, many, not all, but many can survive for months, years, decades.
Wow, that's really amazing. And certainly I could see how that would change your perspective and attitude quite a bit. And I'm reminded of, I think it may have been, I don't know if it's you or one of your colleagues said this, but it's like with the primary diagnosis is a baby, it's a person, it's a human being.
Yep.
And so it needs to be treated as an individual patient. And then the secondary things are things like the trisomies and stuff.
Well, and I think even secondaries maybe is trisomy, but really the most important thing is what are the medical issues that a baby might deal with. That really should dictate what the potential prognosis should be. That doesn't determine the value of the baby's life by any stretch of the imagination. And it should be said that with these particular genetic disorders, trisomy 13, 18, trisomy 9, there's some lesser. Trisomy 13 and 18 are relatively uncommon, but there are some even lesser common trisomies as well that sometimes get lost in the conversations. But most of them, really all of them, when they're so-called full trisomies, have pretty severe mental and physical handicaps associated with them. That, again, in my view, at least, should not determine their value as humans, just as you pointed out. And I think the big challenge is that we in medicine have gotten to a place where we really feel we can judge quality of life for better or for worse. And oftentimes our decisions, treatment plans that we make are biased by those discriminatory thoughts that we may have about certain disabilities.
Mm-hmm. Yeah, that's a really important point. And almost the distinction between the kind of an ethical recommendation versus a medical recommendation.
That's a good way to phrase it. And I think the challenge for parents is that very often they are dealing with the biases of the providers, which pretty generally are not favorable towards suggesting that high quality of life can be achieved with some of these genetic diagnoses. And you layer on top of that now the fact that we are we're offering prenatal genetic testing to every mother. It's no longer just the so-called mom with advanced maternal age. It's every mother is being offered prenatal genetic screening with what we call non-invasive prenatal testing.
So how do parents kind of find their way into this whole world of prenatal testing and diagnosis and stuff like that? So maybe you could, spend a little bit kind of talking about these, the testing that people get, the NIP testing and, first trimesters and stuff like that. What do those mean? What do the results mean? What are the limitations of those things? How they may be misinterpreted, the results and so forth. So.
Sure. I think the biggest movement that we've seen since the mid-20 teens is now the recommendation for non-invasive prenatal testing for all moms who are pregnant. Moms will come in, they'll have their basic pregnancy labs that are done, but somewhere around 10 to 12 to 14 weeks, people will start offering what's called NIPT or non-invasive prenatal testing. This basically is a blood test from the mom. And what is done is the blood is examined for evidence of the baby's genetics. This all seems like it could be rather interesting, but it's a screening test. It's not a diagnostic test. And what we know is that it is possibly more accurate for some genetic disorders than others. So it is a bit more accurate for sure for trisomy 21, really less accurate for things like trisomy 18 and 13. And these companies that are producing these tests are trying to make them more and more accurate, but especially for the rarer trisomies and the ones that we think of as life-limiting, far less accurate. So the problem comes in then is that if every mother is being offered this testing, there are some populations of moms that it's going to be more inaccurate than others. And the moms where this testing is most inaccurate are younger mothers. So if we're testing moms who are 18, 20, 25, 30 years old, these tests are not as accurate basically because these disorders are not as common in that population. They're much more common in older mothers. So the chance that a positive test on an NIPT is real is higher in an older mom. We call this the positive predictive value of the test. That is what every mother would want to know. If I get this test, what is the chance that my result is a real, true positive, if it's positive? On the flip side, you would want to know if it's negative, is it truly negative? There are some issues there as well. But the concern is that, especially with things like 13, 18, and a host of other genetic disorders that now these companies are trying to screen for, the tests are far less accurate. So when moms are told about these tests, there's a huge problem out there with informed consent because moms are not necessarily given all the information they know to make a good decision about whether they want this NIPT blood test or not. So very often a mom will say, yeah, I would like to get that blood test that will tell me the sex of my baby. I want to find out early what my baby's sex is. Little do they realize, other than if they read the fine print on a consent form, that they're going to get test results for a variety of other things. And that's when moms sometimes are just totally shocked and surprised when they get a result on a test that comes back. It's not about the sex of your baby. Your baby may have trisomy 18 or your baby may have trisomy 13. And now what do I do? And exactly as you said, Gary, you're tossed into that abyss of what now? I mean, where do we go now? And so there is a what now. What will be recommended then by obstetricians or women's health providers generally is to go to an amniocentesis. I mean, the problem with amniocentesis is there is some risk with it. It's not a huge risk, but maybe about 1 in 500 to 1 in 1,000 babies are lost with an amniocentesis. So that needs to be seriously considered. As someone once said to me, if you're running a roller coaster and you tell me I have a 1 in 1,000 chance that I'm not coming off alive, I'm probably not getting on that roller coaster. But amnio has become so routine that, and it's talked about so commonly with lay people that I think people just assume there's really not much risk. I know my OB colleagues at UNC talk about this, but I'm not sure in every OB practice across the country that this is really talked about as much as it should be. So there's amniocentesis, or you can do chorionic villus sampling. So amniocentesis being to go in and have a needle inserted through the mom's belly into the amniotic fluid cavity to get fluid out that would contain the baby's cells, or to take a sample of the placenta, chorionic villus sampling. Both of these, though, have those risks for losing the pregnancy. And then you may get what is a diagnostic result. Those tests, amniocentesis and chorionic villus sampling, are diagnostic tests. Non-invasive prenatal testing is a screening test. But again, the problem is very often mothers are going into this without really truly informed consent about what the tests are going to do and what they might reveal and what the questions are that will be raised and what they will have to deal with, or even if they want to deal with those questions.
No, that's great, and some great analogies. I'm thinking about that roller coaster analogy. I imagine like a roller coaster where one or two or three people died every single day on a roller coaster. Probably wouldn't have any riders on it.
Right.
And yet, here we are. I want to go back also to one of the things you're talking about, the screening tests. And I know the screening tests are sometimes marketed as like 99% accurate or something like that. But of course, you're looking for conditions that maybe are 1 in 1,000 or 1 in 5,000 or something like that. When you say it may be wrong, I mean, for a young mother, if you get a positive result on a screening test for a rare condition, how high of a false positive rate could it be for a young mother?
Sure. Yeah. So, what I would say is that the risk for these being inaccurate is really quite high for younger mothers for trisomy 18 and 13. Trisomy 13 is the most difficult to detect right now. Trisomy 18 is a little bit better based on the current testing kits. So if you have a mom who's 20 years old and she tests positive just based on the incidence of how often that occurs in a 20-year-old population, what you would say is probably the chance that that's a true positive is maybe 10 to 20%. And it depends on which test you're using. Some tests are better than others at determining certain types of genetic disorders. So they're not all created equally. What moms can do is go out on the internet and look for NIPT calculators, non-invasive prenatal test calculators. You can go to those and plug in your information about at what gestation your test was done, what kind of test was done, and what your age is. And it will give you a projected positive predictive value. What is the chance that my positive test is a real positive? It will give you a number. And very often, it's less than 50% for trisomy 13 and 18 in a younger mom. So it's really less than a coin flip. You would be better off flipping a coin to determine whether your baby has trisomy 13 or 18, certainly at those younger ages. At the older ages, it becomes a little bit more accurate. Now, to your point about how moms might walk through this journey, amniocentesis or chorionic villus sampling would be recommended. The other tool that we have that can be helpful in trying to determine if there really is a genetic abnormality is ultrasound. So if we're looking at babies, and generally we're doing anatomic scans somewhere around 18 weeks or so, if we're looking and we see significant or several anomalies, say, for instance, in the heart, or maybe in the lung, or maybe in the brain, that may be corroborating evidence with a positive screen that, yeah, there might be something going on here in terms of a true trisomy condition. So that would be the next step down the road in terms of trying to get a handle on what the real potential is for genetic diagnosis in a given case.
I got you right. Basically, a positive result for many young mothers of these things. What it means is they have a perfectly healthy child.
Right,
Is
right,
the most likely
right.
outcome of a positive test, which is kind of odd to say it's a positive result when when it's actually the most likely is the exact opposite. But let's go, on to that. Your point of like, okay, if maybe you've had that screening test, maybe an ultrasound kind of helped to confirm, what the screening test result is, and perhaps there's more significant evidence that in fact actually there's a condition present for a child. Maybe talk about kind of the distinction between there's the presence of a condition and the prognosis of the child, and what may come of it, and the usefulness of intervention and so forth.
Right. Well, let me take a step back to what you just brought up before we even get there. So the problem, as you brought up, is that it's very possible you could have a positive screening test with a normal baby. Now, with the current state of abortion legislation and law in a number of states, what is perceived by parents at times, or certainly perceived by obstetricians and maternal fetal medicine providers at times, is there is a window where abortion is something that's a possibility for a mom legally, and at some point that window will close depending on your state. So there are cases and there's suspicion that this happens not too infrequently, that just based on a positive screening test, that some may recommend going through with an abortion if that a mom is abortion minded. I think that is something that seriously has to be considered as we have more reasonable limits on what we do with abortion. But the flip side of that is people may be feeling that they have to make decisions sooner than they would otherwise about their baby. The fact that you may have a trisomy diagnosis, let's say your genetic test comes back positive, like you said, Gary, and, you have some ultrasound findings. What does that mean for the baby? I think for many healthcare providers, and I'll say this for neonatologists and for maternal providers, that means you have a baby with a condition which is really pretty terrible, and portends a very low quality of life. And that's what the literature will tell us. I mean, people have asked these questions from maternal and neonatal providers, and it's pretty disturbing to see how poor the quality of life is judged to be by folks on both sides of that care spectrum. So very often, what is the initial recommendation then? Just based on a generic diagnosis of trisomy 13 or 18, the first knee-jerk reflex is abortion. That is what moms generally are offered initially. That's what the literature will tell us. Not in all cases, for sure. And I think there are some places that have gotten better at this point. But the best literature that we have suggests that that is absolutely the case. And that's literature that comes from parents who've been down this road and been on this journey.
And of those, I mean, how many of them are also offered a referral to a medical expert that treats children with particular conditions?
Yeah, I don't think we have good data on that. I have pretty extensive anecdotal experience, having done this for heading on 15 years now with Be Not Afraid and being very active on the Facebook sites for these genetic conditions. It's not common that off of the bat, people are offered referrals like to, say, a neonatologist, a cardiologist, and maybe a peds surgeon based on what they're seeing in the baby on ultrasound. The initial reflex consult is usually, do you want to think about termination and abortion?
Mm-hmm. Yeah. And yeah, I mean, obviously, and this is their doctor, who's maybe, first things out is saying abortion and not necessarily saying, hey, let's go explore kind of what your child's needs may be, and, what treatment options or care options may exist, along the way. So I could see that could be certainly a challenging perspective on things.
What we tried to do here in North Carolina when we passed our abortion legislation a few years ago is to build in to the law a requirement when there was a diagnosis that was made of a potentially life-limiting or quote-unquote lethal disorder, that parents would be offered exactly what you described, expert consultation with physicians who would talk about the potential for life for the baby, what that would look like, what interventions might need to be for that child. And it is part of the law, but there's really no enforcement mechanism for it, which is unfortunate. So it's strongly suggested, but it's not being tracked. But that is what you would hope for. So we oftentimes fail in informed consent on the front end when we offer this genetic testing. We very often fail on the backside when we get a positive genetic test to inform parents, here are your options. Okay, we all know that people are going to be offered abortion. I mean, that's going to happen. That happens every time. But the other options would be, number one, do you want to think about carrying your baby to a live birth? And if there are really severe issues with the baby, talk about perinatal hospice or comfort care. Or the third option is, there may be things we can do for your baby. And we're showing more and more now that there's long-term survivals for these babies with these rare genetic conditions when we are willing to say that their life can be valuable and we're willing to offer them care.
A child with trisomy 13 or 18, I know there's probably a collection of more common, medical needs that present themselves. Maybe talk about some, just as an example, kind of the sort of care or treatments you may offer. And I know each child is unique, so you're not talking about a specific,
right,
everything, but yeah.
Yeah. So there are some commonalities, and I do tend to group, genetic disorders like trisomy 13 and 18 together. I think more because they've just been looked at as lethal, and everyone else has always just thrown them kind of into the same bucket. Interestingly, for some reason, trisomy 13, I think, has always been looked at as a little bit more lethal. And I think I have a suspicion why. Babies with trisomy 13 more often will have facial anomalies. They more commonly have clefts, cleft palate, cleft lips, facial anomalies, very small eyes, sometimes absent eyes. Their midline structures are sometimes really not well grown, and the optic nerves go to the eyes. That's a midline structure. And so oftentimes they are very different looking kids. And if you look in the congenital malformation textbooks, you'll find all sorts of terrible pictures of children with different types of abnormalities and deformities. Very rarely do you see pictures of kids that are a year, 5 years, 10 years old, loving members of their family, having a blast, which has been my privilege. But the common things that these genetic sort of conditions seem to have congenitally are heart issues for sure. Trisomy 13 and 18, 85 to 90% of the babies will have a significant heart condition. Not all of them will require surgery, but a good number would. But the best data that we have over last several decades is maybe about 10 to 15% of those kids have actually gotten surgery, where probably about 60 to 70% of them deserve surgery. So we clearly have had a bias in not wanting to bring these kids to cardiac surgery. And if you've got a significant cardiac defect that we could fix, for instance, something called a ventricular septal defect, a hole between the two lower pumping chambers, one of the most common heart defects we see in any baby, but very common in trisomy 18 and 13. We fix those routinely in babies with normal chromosomes at about 4 to 6 months of age, generally. If you refuse to do it, you would probably have people demanding that they take your child away and be bringing in the maternal child welfare advocates, because people would consider it basically abusive. I mean, because it's totally treatable, survivable condition. But in cases where you have trisomy 13 and 18, we still are kind of stuck in the life limiting and that sort of nomenclature. And, it's not something that is as commonly done as it could be. So what happens then if you have a big VSD, again, one of the most common heart defects, and you don't fix it, what will happen is a baby will develop things like high blood pressure in the lungs, and that may ultimately be what will kill the baby by a year, 2 years, 3 years of age, if they live that long. So the babies with trisomy 13 and 18, with their heart conditions, they are a little bit higher risk. They're higher risk surgical candidates, but it's not a death sentence to send them to surgery. And very often we portray it as a death sentence to send them to surgery as providers. Very common, I'll hear from families being told, you don't want to send your baby to surgery because they'll die during the surgery. They'll get very bad pulmonary hypertension during the surgery, high blood pressure in the lungs during the surgery. They may not come out of the operating room. But what we know is, based on pretty good data over the last 10 years, is that if you have a VSD, most common heart defect that cardiac surgeons operate on for children, the operative mortality for that in a baby with normal chromosomes is about 0.5%. The operative mortality for that for a baby with trisomy 13 or 18 is about 5%. So it's 10 times higher. It's a lot higher, but 95% of them can survive and get through the post-op period and get home. So, I think we are in a phase, I hope, where we're moving towards the recognition that these are lives that have proven themselves to obviously be worth living. I mean, they're human beings, but they can have really rewarding and valuable lives with their families. I mean, it may not be the life that many doctors would want for their own child, but as the father of a child with severe developmental disabilities, I could tell you, it's a pretty rewarding, if challenging, life. I mean, I wouldn't trade it for anything. So heart defects are one of the big issues. The other issue that's a big problem with a lot of the babies is breathing-related issues. And there, for many decades, has been this thought that babies with trisomy 13 and 18, when they're born, their brains may not be fully developed and they don't know how to breathe. So when we don't breathe, we call that apnea. That basically means absence of breathing. And so when you don't breathe because your brain isn't telling you to breathe, we call that central apnea. So what I was raised with for decades as a pediatric resident, pediatrician, and neonatologist is that when a trisomy baby comes out, 13 or 18 trisomy 9, any trisomy baby, not Down syndrome, and they don't breathe, that's probably a sign that their brain isn't developed enough to tell them when to breathe, and they're probably going to die. What we know now, because people have saved a lot of these babies, is that it's not central apnea and their brain's not telling them to breathe. What happens is their airways are actually very collapsible. So when they're breathing, sometimes their airways collapse and they can't move air. And if they're trying to move air and they're breathing back and forth, and all of a sudden they just say, I'm too tired, can't do it anymore, and they just stop breathing, that's obstructive apnea. We have ways to treat that. We can treat it by things like CPAP, like we do with adults who have obstructive apnea at night. We can do things if we need to, like tracheostomies. And maybe every parent wouldn't want to do that, but they should be offered this information and allowed to make those decisions. But I would say the two biggest issues, certainly early on, are related to the heart and the breathing.
Well, thank you. And I mean, it just sounds like, medical advances continue to find ways to really provide, care and treatment for all these children. And I think you've kind of touched on this, earlier, but you keep on going back to it. And I think it's an important point is the whole notion of informed consent, which is really the basis, I understand, for all medical ethics. But maybe you might talk about kind of, we've talked about so many ways how parents are not receiving informed consent. Maybe you can, share like, okay, what would your ideal be for what informed consent looks like for parents?
Yeah, I think there are more and more places that are giving parents the informed consent that they need. So I think the ideal process would be for parents who are dealing with a diagnosis like this, and there are other things too, not just these genetic disorders, but there's lots of other maybe heart defects that aren't associated with genetics per se, or lung defects that are diaphragmatic hernias, a host of things that what parents should be told is what the potential is for life. I think we should operate from that principle. I mean, obviously, I'm a little biased about that, but and what potential treatments are out there. If a baby has a significant anomaly, families are. It's just not even a second thought. They're all offered abortion, and then I think perinatal hospice has a role as well. But I think personally, when we just sort of reflexively fall back on perinatal hospice and comfort care for these babies, what we're doing is basically saying the baby has no chance to survive. Yes, we avoid an abortion, which we all want that because the abortion is catastrophic for the mom, certainly for the baby. But if all we're offering is comfort care in a baby who could survive, we're just delaying the demise of the baby. And it may be in a way that's a little bit more acceptable to the family, but I really worry, Gary, that a lot of families are not informed about that third choice, that they could be offered interventions. And if they make a decision that, if my baby needs heart surgery or tracheostomy and they don't want to do that, let them make that informed decision, but let it be informed. And I think what's critically important to help get parents down this road to make sure they understand what informed consent should be for them is exactly what we're doing with prenatal diagnosis and the website and the materials that are available there and informing families and the organizations around the country that are trained in helping walk with these families down this road. It is incredibly challenging and really difficult to try and go up against doctors who are telling you your baby has no chance to survive. Why would you do this? And all you've got is what you've seen maybe on a Facebook group or what some mom told you, in a call that you may have made on a connection off a Facebook group. Those things can be helpful and powerful and open people's eyes. But I think you really have to have people who are committed to walking with these families down this road on a regular basis, like even weekly and sometimes daily, to try and help them through the challenging moments of this prenatal and postnatal journey.
Yeah, well, thanks. You're definitely shifting to the kind of the last part I really wanted to cover is the support for parents and how that support you're talking about can work hopefully in a complementary way with the medical community. There's a near and dear friend to both you and I, Tracy Windsor, you mentioned earlier, and Be Not Afraid, the organization she developed and kind of the model of care that she helped develop that we're also bringing to other pregnancy centers as well to do. Maybe share a little bit kind of your perspective on that support model and the value of that.
Yeah, I think what you say, hopefully in partnership with the medical community, I think in some places that is happening in terms of groups that are working with the moms and the parents walking down this road. But sometimes it's an oppositional kind of relationship. I mean, there are places where just culturally they're not willing to support these families. And so I think these groups are really, really important, and that's a very tricky dance to do with parents who are in a place where they don't have much choice, but they're dealing with challenging medical providers. But I think what anyone who's doing this work has to realize up front is that the day the parents get a prenatal diagnosis is the day that trauma begins for them. I mean, their world gets stood on its head at this point. These are wanted pregnancies, right? I mean, these are babies that there were great hopes for, and now you're telling me that my baby has this big problem, and my baby is not going to be what I thought my baby was going to be. I mean, the hopes and dreams that I had for my baby are looking like they're going away. And in some ways, on that day and those days that follow, you're already dealing with the death of the child you thought you had. And then you need somebody to help you come to grips with the fact that your child's not dead, but there's a different world out there that can be very rewarding, but it's going to take some time to really understand this and figure your way through this darkness to get where you can find some light. And I think the groups that are working with these families, critically important that we get to them as soon as we can to their day of diagnosis. The longer that they go after that day of diagnosis, the more challenging it is to work with those families. I think what we try and do with those families is listen, first of all, and not tell them how things will be or should be, but understand absolutely where they're at, understand what their wishes are, and then start to try and inform them about the possibilities for their baby. Right up front, that's not something that they necessarily need to hear. They need someone
really
who
understand their options.
Yeah, they need
Yeah.
someone who understands the trauma they're experiencing right now. And then over time, if we can get to families and parents, around 16, 18, 20 weeks, we have a good number of months to work with them and try and walk down this road with them and understand what their desires really are for their baby. I think where we hope to get requires lots of hard work. It's lots of contact with the families. Like I said, it can't be done with a website. It can't be done with just a Facebook group. It needs to be committed parent care assistance, parent care support, parent care coordinators is what we call them in the Be Not Afraid model. And I think that's critical. I think people who are going to do this work need to be well versed not only in trauma-informed care, but they need to understand a fair bit about the genetic conditions, the genetic testing, be able to confront some of the information that parents are being given, either confirm it or talk about why maybe there might be another story here and it's a little bit different than you might be hearing. Help support parents in developing alternative plans. And then I think every parent in this situation really needs to sit down with a parent care coordinator and develop a birth plan. You have to have a birth plan. I think you need to put down on paper in your mind exactly what you think you want to have happen for your baby. And it's not down necessarily to the minute details about some of the birth plans that can be really challenging with well deliveries for us, like the issues of immunizations or vitamin K or water birth or all that kind of stuff. It's really about what I want done for my monitoring, what I want done for my prenatal care, and then what I want done for my baby at the time of birth and afterwards, and what my expectations are. And by the way, I would like to meet with the people who will be caring for my baby, the neonatologist, the cardiologist, whoever it may be. It's not uncommon that parents are just given a prenatal diagnosis, and really it's the obstetrician or the maternal provider in many places who is saying, well, if you don't want to terminate your pregnancy, we'll do perinatal hospice, we'll do comfort care, and parents aren't aware that there's another alternative, and they're never offered, as you mentioned earlier, a conversation with a neonatologist or, a referral for a pediatric echocardiogram to see what their heart defect really is.
Just listening to talk and Tracy and I have talked about this sort of thing many times as well. But those of us who come from the kind of the more traditional pregnancy help model know that we have to meet women at the moment of crisis, which is a different moment between the two, but then journey with them, meeting their needs along the way. And the model that we use is called the love approach, but it's so similar the needs here. Just, start off by listening to parents, discuss options, you have the option to carry to term, things like that. And just, just reminding the value of every child, no matter what the situation is with the child is in, and just being able to empower those parents to really kind of face the road ahead. The needs are different between the two, but the journey that we walk alongside them is very similar. And we've been able to take some of the Be Not Afraid model of care and bring it to a number of pregnancy help centers, and we continue to expand those number
Yeah.
of pregnancy help organizations that are trained in that model of care. And it makes sense to them. I've spoken to a number of them because they can see the parallel journey along the way with that. So we're really privileged to be able to work with you and with Be Not Afraid to be able to bring that out to others. And then you mentioned a website doesn't solve the problem, but we do have a website called prenataldiagnosis.org that is there mostly just to help parents find that there are people willing to
Yes.
walk with them and willing to walk the journey with them.
Yeah,
And
I think, Gary, I think there are a number. Facebook is full of, not full of, but there are a number of websites for people with a variety of genetic issues or other prenatal diagnoses to go to. And I think they can be helpful. But, when you're there, you're interacting with one person, oftentimes one mother, and you're getting one experience. And it's not necessarily your experience. And you're not dealing with someone who's trauma-informed and who really understands the bigger picture. So I think prenatal diagnosis is absolutely critical because it is the conduit for referrals. It will get people to the organizations that will be able to walk with them. And I think that absolutely has to happen. I mean, Be Not Afraid has morphed now into a training organization. It is so crystal clear. There are so many women across the country that need this support that formally as a service organization, we could never support anywhere close to all those people. But we do have a model of care that can really be used to train people in multiple organizations to get this work done. So I think that is really critical, that we build more of these organizations. And I think pregnancy resource centers are a great option. We are utilizing that option here in Raleigh. So we are partnering with Birth Choice. We have 2 people in training right now with Be Not Afraid. We have a third going in May. And our next training for Be Not Afraid will be May 1st. Registration is open into the middle of April. So if there are folks out there with an organization that are interested in training their people to help better deal with moms dealing with a prenatal diagnosis, that's the place to go. www.benotafraid is the place to be.
Yeah, well, thank you for that, Dr. McCaffrey. And for any pregnancy help organization listening to this, you have that as a resource. Prenataldiagnosis.org can help any parents that you encounter connect with with a parent care coordinator that's especially trained in this as well. This whole area is such an important part of pregnancy help, even though it's a smaller percentage of the population overall. Is just every single one of these children are precious. Just as Dr. McCaffrey said a moment ago. So, thank you so much for the time, Dr. McCaffrey and
You're
Christine.
welcome.
Yeah.
Thank you both so much. Such an interesting conversation. We so appreciate the medical perspective and the explanations of how the testing works and what those diagnoses really mean. It's so helpful for us to better understand. Those links that we mentioned will be available in the show notes. The Be Not Afraid registration link, I have a direct link to that in the show notes as well. I have links to the other podcasts, to some of our webinars, our workshops and things on this topic. So you'll have a whole list in the show notes of resources to check out for more. Also subscribe to the podcast because we've covered this in the past. We'll be covering it in the future as we bring on other guests and just help us to understand how pregnancy help organizations can better serve those families facing a prenatal diagnosis. So please subscribe to the podcast, share with others in other pregnancy help organizations. And thank you for listening to this episode of the Pregnancy Help Podcast.